Yeah, good afternoon, everybody. I am Dr. Pallav Bhatia. I will be presenting cases of foraminal stenosis. So this is first case. She is a 45 years old female. She is having neck pain, left upper limb radicular pain in C6 dermatome, left scapular pain since almost 6 months. Her neurology is normal. She has tried all the conservative management, but that has failed. So this is the MRI of this patient, and we can see multi-level disc degeneration along with a foraminal stenosis, left side foraminal stenosis at C5, C6. And this is the X-ray. So all conservative trial has been taken by this patient, but she gets some bit of pain relief, but again she presents with the same complaints. So how do we go ahead with this case?
I am not sure of the pain generator on seeing this MRI. I am not convinced about the clinical symptom with the MRI because I can't find a compatible finding there. Tushar, your opinion?
In such situation, I will like to give a block. I ask pain specialist to give a block and see whether the symptoms are because of the same.
Exactly my sentiments, Tushar.
Again, can we see that axial? You said the foraminal stenosis. Which one?
Yeah, at C5, C6, left side.
Ajay sir, are you convinced?
With this image, I think the way it has been shot, there is a glare of the camera when you took the shoot. So I'm not able to appreciate much. Yeah, there could be something, but I'm not sure. And we, whenever considering foraminal stenosis, two standard films we take, we specifically order for oblique MRI films, because it is not the MRI of the lumbar wherein foraminal stenosis is assessed on the parasagittal image. This needs because it's at an angle, the foramen is at an angle, it's not sagittal, it is parasagittal. And oblique, that's why you need an oblique cut to evaluate on an MRI in doubtful cases. Wherever it is very evident, not those cases, wherein clinically you are suspecting and you are not finding on MRI, you get an oblique film that helps. You take oblique X-rays. If it is a chronic, then you are able to see good foraminal stenosis there. So this is a standard protocol we follow for a radiculopathy if not convincing on MRI.
Okay.
CT scan is the next step. So the primary evaluation is this, because this we have in-house. CT scan would be another thing which would add.
Senior consultants, Parasnis sir, Vishal Peshitiva sir, any take on this?
There are two things always, image and the correlation with the clinical findings. But so many times brachyalgia, the pain classically going to C5 or C6, we always look at foramen, but we have to remember beyond the foramen there could be so many regenerators of the pain. So unless you're very sure with a doubtful film, don't be in a hurry to take any kind of invasive approach to the pain modality.
Even Tushar though said that he will give a block. The moment you have put a needle or knife on the patient, every onus is on you. I have one of my pain colleague for a radicular pain. He intervened and given a block. He was right in justification of all his MRI. There was a clear-cut disc, pain, everything. And once block given, twice block given in 4 days. And the patient was having an intestinal gangrene. So there can be so much overlaps. So before putting your any intervention includes needle, because as long as you have missed the diagnosis, that's not a problem. Nobody will catch you probably. But the moment you have put your knife or needle, responsibility will shift on to you. वेताल आपके ऊपर बैठ जाएगा.
Right. So I would like to ask, how many of you give cervical epidural blocks in your practice?
We have a pain specialist with us, so generally I don't give a cervical blocks.
Achha. And okay, yeah. So
I used to give significantly many numbers when I was in initial practices and years. I stopped it because of want of time. and I don't rely too much on the interventional guy to do it. Yes, my fellows who are with us for longer time, we are trying to emulate the same things.
Okay. So I gave cervical epidural block in this patient, and I routinely give cervical epidural blocks. And I will say that in my practice, almost, and this is after when I attended a pain management course. So they also told that 60% of the cases, surgical cases of whatever ACDF or so, have been reduced after they have shifted to the blocks. So
It is a very great and good message what Pallav yes, na? Pallav is giving. See, at this stage, after 15 years of practice, when I am telling my patient to get operated, they surrender. But all those who are sitting and are youth or young and who are trained know to do the surgery, but once you tell the patient about surgery, the patient rushes to us or anybody who is senior in the town and you miss the patient. It is always the pain intervention injections you should have in hand. Even if you do it for free, then also the patient is with you. So it is more of conservative for youngsters than even for seniors. This is just some message I would like to pass on to the most juniors, because you try to grab an operative patient and the moment you tell the surgery to the patient and the patient runs away. Initially the patient doesn't get convinced in the first 5 years of a practice or 3 years of practice. There's a truth. We have faced it. Probably you may be facing it.
yeah, so that's what. And you said it very true, sir, that if you give a block, and suppose if the block even didn't work well, they will not like stab you. But most of my 95% of the cases, block works very well, and patient has very good relief. This patient is followed up since 1 year with me, and she's still not having any kind of pain. And I
Yeah, this is something even Bharat sir and my seniors, others have also told. My conservative patients or our conservative patients brings more patients
more
to us.
patients, yeah.
And the operative patients, whatever's done in spine, your outcome, if thorough literature search is done, is around 60% good outcome to excellent outcome. 40% you have something or other, and they don't send patients to you.
True that.
So,
And these pain management techniques should be in your armor. Too.
Yeah.
Please go ahead.
Can I just ask one question, please? So you said in such cases, to establish diagnosis, we discuss CT scan, oblique MRIs. Role of NCV studies in such cases? Your take on it, sir?
No.
Neuroconduction studies?
It's not there. There are specific neurophysiologists who are there on whose words we rely. Specifically for in double crush syndromes and with the other modalities, if we are not able to identify, definitely we go in for EMG and CVS. But these all are cases wherein you are in doubt. We do rely, but it is not on all the neurophysiologists give the same report. So you have to be very choosy about whom you are going to rely.
So it depends on the neurophysician who is reporting.
Yes, it is significantly important. There are so many, even with deficit patients, there are so many overlapping diagnoses which is there. Monoradicopathy, whether you agree or not, seniors, and I've seen noticing in Parkinson's patient. Parkinson's produces monoradiculopathy, lower limb, upper limb. These are all, if you start interacting with your neurophysio colleagues, you will come to know. The Turner syndrome, the brachialgia, neuritis, this all is very common and overlapping. Even for cervical myelopathies, there are so much overlapping is there.
Correct.
So before your knife, it is better.
Because same patient, two different neurophysiologists, two different reports. I have seen many times this. So I send that patient to a very specific neurophysiologist on whom I believe.
Yeah, that's what key. How much to rely on these EMG NCV studies?
Yes,
Because these
you
are very,
cannot.
very much confusing.
Because even there is a deficit, the EMG shows the normal study.
Normal
so how
study.
much you can rely on that?
Yeah.
One really highly trained neurologist told me, if there is no significant deficit, there will be no problem in EMG and nerve conduction. So it is only useful when you have clinical detection, not subtle sign. Subtle signs are not picked in cases of myeloradicopathy in any case. So if you want to just tick the slot, then it's fine, otherwise no.
Okay. So this is second case. She's a female of 65 years, having severe neck pain, left upper limb radicular pain in C6 dermatome. And neurologically, power is intact, but sensations are decreased in left C6 dermatome, and all conservative trials have failed. So this is the MRI. And so there is a foraminal disc. She is not having any myelopathic signs. Although in the sagittal MRI, if we see that there is a slight posterior compression and slight changes. So how would you like to go in this patient?
Do you have a CT for this?
And no, CT is not there, right?
X-ray you have?
Oh, sorry.
Appears to be a hard disk to me actually, that is why I was asking. Dr. Ajay?
Now it is quite evident from this, provided that all clinical things are concluded and many of the other things which is parallelly going on, it's outrightly driven out. We can go in and consider for a surgery in this case, definitely. Why not?
You would go for an anterior or posterior surgery?
I'll go for an anterior in this case because I see some subtle changes in cord. Though it is a radiculopathy, it is probably a myeloradiculopathy and very subtle signs of the neurograde 1 myelopathy, it may be there. So neurograde 1 itself is radiculopathy.
Right. Anybody who would like to go posteriorly? Because there is a posterior, yeah, yes, sir.
This patient might require a flexion extension MRI. That will clear all the doubts whether there is a subtle instability. And if there is a subtle instability, it becomes very clear that which approach you need to take.
So if you look at the posterior, there's a definitely buckling of ligamentum flavum. And that happens because, and the signal changes there. So, although it's only radiculopathy, and only if the posteriors were fine, I would have gone for amyotomy, and that is my choice. But looking at the cord changes and the posterior buckling, 100% anterior, because that solves everything. The moment you put a good size anterior support, the buckling is just because of the collapse, and all these things resolve. So had it not be that posterior buckling and the subtle signs, my approach always is posterior endoscopic foraminotomy, because that is very good, but not in this case because of the whatever I told.
Beautifully.
I have started using one of the other indications to evaluate whether foraminotomy posterior works or not. An extension and rotation of the neck, if it aggravates the symptom, that probably guides towards a posterior foraminotomy in radiculopathy patient. Is it a correct way of approach? Yeah, so that is to make a decision.
Yeah. So I also went anterior in this case, and patient recovered quite well with all her symptoms.
Okay. Thank you, Pallav,
Thank you.
for the
Thank you so much.
two cases. I think we'll move on to the last speaker.